Hi everyone, welcome to this GI author interview series. My name is Mehul Lamba and I'm currently a therapeutic endoscopy fellow at St. Michael's Hospital, Toronto. On behalf of my co-authors, I'd like to discuss our article titled Clinical Utility of Purgative Bowel Preparation Prior to Capsule Endoscopy, a multicenter, blinded, randomized controlled trial. I'd like to thank the editors at Gastrointestinal Endoscopy for accepting our manuscript and for giving us an opportunity to discuss the findings of our study. Since the advent of capsule endoscopy over 20 years ago, the clinical applications have expanded, and capsule endoscopy is now an investigation of choice for patients with suspected small bowel bleeding. However, optimal bowel preparation prior to capsule endoscopy remains an area of controversy. Over the last 2 decades, at least 8 randomized controlled trials have been performed assessing utility of PEG-based preparation, yielding heterogeneous results. Majority of these studies had small sample size and used subjective scores to assess diagnostic yield and visualization quality, contributing to the observed heterogeneity. We set up a multicenter randomized controlled trial in 2014 across 5 tertiary hospitals in Australia and New Zealand to assess clinical effectiveness of 2 types of PEG-based preparation compared to clear fluid diet only. The primary outcome was assessment of diagnostic yield based on Sorin score, where lesions were classified as either highly relevant, that is P2 lesions, or less relevant lesions, that is P0 and P1 lesions for GI bleeding. Secondary outcomes included assessment of small bowel visualization quality, small bowel transit times, and patient tolerance. All consecutive patients over 18 years of age who presented with obscure GI bleeding and negative bidirectional endoscopy were considered for enrollment. Patients with significant comorbidities, such as congestive heart failure or end-stage renal failure, which would preclude large volume bowel preparation, were excluded from the study. Similarly, patients with suspected small bowel strictures were excluded. Patients were randomized centrally into one of the 3 arms. Patients in Arm A were instructed to follow a clear fluid diet for 18 hours prior and fasting for 6 hours before the capsule endoscopy. Patients in Arm B, in addition to clear fluid diet, were asked to take 2 liters of PEG-based preparation 12 hours prior. Patients allocated to Arm C, in addition to clear fluid diet, were asked to take 1 liter of PEG-based preparation 3 hours before the capsule endoscopy. All patients were asked to swallow the capsule with 200 milligrams of simethicone in 150 ml of water. All capsule endoscopies were reported by accredited gastroenterologists in a blinded manner using standardized reporting sheets. Assuming 60% incidence rate of P2 lesions, we estimated that 152 patients were required to be recruited per arm to show a 15% clinical benefit. Assuming a 60% incidence rate of P2 lesions, we estimated that 152 patients were required to be recruited per arm to show a 15% benefit in diagnostic yield, with an alpha of 0.05 and statistical power of 0.8. The study, however, was discontinued early based on a pre-specified interim analysis performed at 50% enrollment on grounds of likely futility with continuation of study recruitment. The Bayesian predictive probability of rejecting null hypothesis should the trial be allowed to continue full recruitment was 0.064. Overall, during the 5-year period, 524 patients were screened, of which 237 patients were randomized and 229 patients completed the study. This included 78 patients in the clear fluid arm, 76 patients in 2 liter PEG arm, and 75 patients in 1 liter PEG arm. Baseline characteristics of recruited patients, including age, gender, comorbidities, and proportion of patients with overt GI bleeding, was similar across the 3 arms. The incidence of highly relevant P2 lesions was remarkably similar across the three arms, with 48.7% in the clear fluid arm, 48% in 2 liter PEG arm, and 45.9% in the 1 liter PEG arm, with a p-value of 0.94. Further, there were no significant differences in presence of less relevant P0 or P1 lesions across the three arms. The small bowel visualization quality was assessed using a validated quantitative broad score. We did not find any significant difference in visualization quality of overall small bowel or distal small bowel across the study groups. Similarly, the gastric emptying time and small bowel transit time, as assessed by the capsule movement, was similar across the study groups. We collected data on adverse effects shown on the left, as well as patient tolerance using a visual analog scale on the right, where lower score indicated better tolerance. Symptoms of GI intolerance, such as nausea, vomiting, pain, or bloating, was significantly more common in patients allocated to oral purgatives compared to clear fluid diet. One of the limitations of a study is that only patients with suspected GI bleeding were included. Therefore, generalization of our results to patients with other indications requires caution. Secondly, our study was terminated early on the basis of a pre-specified interim analysis. However, given that there was no improvement in small bowel visualization quality with addition of purgatives, it was felt extremely unlikely that any clinically meaningful benefit in diagnostic yield would be observed had the trial been allowed to complete full recruitment. Notwithstanding the above, our study is one of the largest randomized controlled trials performed to assess optimal bowel preparation prior to capsule endoscopy. To conclude, in this multicenter blinded randomized controlled trial, we did not observe any improvement in diagnostic yield or small bowel visualization quality in patients taking 2 liters PEG-based preparation or 1 liter PEG-based preparation compared to clear fluid diet. Intuitively, PEG-based preparation was associated with higher GI adverse effects and lower patient tolerance. Therefore, results of our study do not support routine use of PEG-based preparation prior to capsule endoscopy. Thank you for listening.